Greetings from Indian Journal of Anaesthesia. I, Dr. Iniki Sharma, will be presenting an article published in the March 2024 issue of the Indian Journal of Anaesthesia. It is titled Evaluating the Efficacy of a Smartphone Application in Reducing Preoperative Anxiety in Children, a randomized controlled trial. Preoperative anxiety affects up to 60% of children undergoing surgery. It can lead to adverse outcomes like emergence agitation and maladaptive behaviors. Parental presence may increase satisfaction but does not always reduce the anxiety levels. Education interventions like video modeling shows promise in reducing anxiety. A smartphone app with educational videos may effectively lower anxiety and improve the outcomes. This study aims to compare the smartphone app's effectiveness against conventional care in reducing anxiety, emergence delirium, and maladaptive behaviors. So the primary objective was to find out the effectiveness of mobile phone app versus conventional method in reducing preoperative anxiety in children of age 4 to 10 years of age for elective surgical procedures. The secondary objective was the impact on emergence delirium, parental satisfaction, and post-operative maladaptive behaviors. Institutional Ethical Committee approval was taken, the trial was registered, and it was a randomized controlled trial with ASA 1 to 2 grade and child 4 to 20 years of age coming for elective ENT procedures. Emergency surgeries, neuropsychiatric conditions requiring psychoactive medications, or significant visual or hearing impairments, or with obstructive sleep apnea were excluded from the study. Written informed consent was taken from the legal guardians of the children, and if they were more than 8 years, then the verbal consent from child was also taken. So a 11-minute educational video in Chinese was prepared, which was a non-interactive one-way content. And this video had 6 segments for each stage of perioperative experience. Preoperatively in the ward, surgery waiting area, entry in the OT and anesthesia induction, post-anesthesia recovery, sedative separation, and post-operative care. This video was seen by both child and the legal guardian of the children. It could be seen any number of times, and any segment could be assessed at any point of time by using a QR code to assess the video on the phone. 2 groups were allocated, divided using a computer-generated random number table, and allocation concealment was done by sequentially numbered opaque sealed envelopes. Group C was without access to smartphone, and Group MT was with access to smartphone. 30 minutes before the procedure, the patient arrived in the preoperative area with the legal guardian, and the child chose a sticker and lollipop for comfort. In the OT, ASA standards monitors were attached, and anesthesia was induced with sevoflurane, after which a IV line was taken and remifentanil and rocuronium was given, following which a supraglottic device was inserted, and the maintenance was done with sevoflurane with remifentanil infusion. The children's anxiety levels were measured with modified Yale preoperative anxiety scale short form. It consists of 4 behavioral categories: activity, state of apparent arousal, vocalization, and emotional expression. Patient cooperation during induction by pediatric anesthesia behavior score was calculated, and it also had 3 categories. The child was either happy, calm, controlled, or compliant. Second category was sad, tearful, withdrawn, but compliant. And the third category was mad, loud, with vocal resistance and non-compliant. So these were the time points at which the anxiety skills were assessed, both for the children and for the guardians. For the children at all time points till before anesthesia induction, whereas for the guardian till the holding area of the operating room. The primary outcome was to evaluate the children's anxiety immediately before anesthesia induction, and the secondary outcome was parental anxiety assessed by BAS and patient cooperation during mask induction. Sample size was calculated based on a previous study at 80% power and 0.05 alpha, 47 per group. and the total sample size to prevent dropouts was 52 per group. So this is a table showing the consort flowchart, and these are the characteristics of the children and guardian, the baseline table where both are divided equally between the two groups. Coming to the primary outcome, the children's anesthesia, the anxiety levels of the children at before anesthesia induction was significantly lower in the group where smartphone based, where it was shown in the smartphone app based group. And for the guardians also, the anxiety levels were significantly lower in the smartphone based group before anesthesia induction. The pediatric anesthesia behavioral score was maximum number of children were calm, that is category 1, which was significantly higher in the mobile phone app based group. So smartphone app with preoperative educational videos significantly reduce anxiety in children undergoing ENT surgery. The app also had anxiolytic effect on the guardians and improved the pediatric cooperation during anesthesia induction. This app's effectiveness aligns with previous research supporting video-based intervention over pharmacological approaches. Parental anxiety was also reduced, supporting the role of preoperative education in easing caregiver distress. So smartphone apps offer a practical, widely accessible solution for preoperative preparation, especially in time-constrained hospital settings. The study limitations include its focus on ENT surgeries, lack of blinding for children and guardians, and also limited interactivity in the video content. Future improvements could include more interactive elements to enhance engagement for pediatric patients. So from this study, the smartphone app demonstrated significant effectiveness in reducing preoperative anxiety in pediatric patients. It provides a simple and accessible tool for delivering preoperative education and addressing anxiety efficiently in children undergoing surgery. Thank you.